Preterm labor. Preterm labor refers to a labor that begins too early, so between 20 and 37 weeks of pregnancy. And it's characterized by cervical changes, so either dilation or effacement. And remember, labor after 37 weeks is considered full term, and labor before 20 weeks is categorized as a spontaneous abortion, as the newborn will not survive. Preterm labor is the #1 cause of neonatal mortality. As babies come out of the womb too soon, they do not have fully developed organs. For example, the lungs do not have maturity to breathe on their own, and the chambers in the heart have not fully closed just yet. These are just to name a few. Sort of like a cake coming out of the oven too soon. It is not fully cooked. In the same way, the little baby is like a bun in the oven that comes out too soon and does not have enough time to fully cook or develop. Naturally, we will see less complications the longer the baby stays in the womb. Moving on to causes and risk factors. We like to use the memory trick DIPS, like the baby is dipping out too soon. The first D is for distended uterus. This is where the uterus gets stretched out. This tricks the body into thinking the pregnancy is further along than it actually is. Some causes include fetal macrosomia, which is that big baby, polyhydramnios, too much amniotic fluid, and multiple gestation, so either twins, triplets, or more. The next D is for diseases. So we have diabetes mellitus, which often yields big babies. So we have that fetal macrosomia, eclampsia. Remember, that is that high blood pressure during pregnancy. Heart disease and anemia. So you'll see a hemoglobin of less than 10 in this situation. Now, I is for infection. Preterm labor and infection are directly related. Typically, if you find one, then you look for the other, as infection makes the body produce prostaglandins, which can increase early uterine contractions. Common infections include UTI, so your urinary tract infections, STI, those sexually transmitted infections, and periodontal disease, or a gum infection within the mouth. This is a huge NCLEX tip, that bacteria in the mouth can actually break down fetal membranes, causing the water to break, which then induces labor. This is called PROM, that premature rupture of membranes, which we cover in full detail in a separate video. Now, the P is for placenta abruption. This is where the placenta separates from the wall of the uterus during pregnancy, and it is most commonly due to trauma. Unfortunately, when this happens, the baby is left with no means of getting oxygen, and it will go hypoxic from that lack of blood supply. So the only option is an emergent C-section to save that baby. Next, we have S for stress. Whether it's emotional or physical, the body releases stress hormones that will initiate labor. Women with depression are twice as likely to have preterm labor than women who do not have depression. The next S is for short cervical length, or too thin of a cervix, also called cervical insufficiency. Basically, the cervix, which is that door to the uterus, is not staying shut. This makes it more likely for preterm labor to occur. The last S is for smoking and stimulants, like cocaine. Now, other risk factors include a history of preterm births. This is important as it's the #1 risk factor for preterm labor. So write that down, the history of preterm births. And lifting heavy objects if you are at risk, as mentioned by ATI. Now, an ATI question. A 42-year-old pregnant client at risk of preterm labor, which information from the nurse is correct regarding prevention of preterm labor? And the answer would be to not lift heavy bags of groceries or young children, which require the use of abdominal muscles. The second question, which of the following factors increases the client's risk of preterm labor? Select all that apply. This would be urinary tract infection, multifetal pregnancy, and diabetes mellitus. Lastly, HESI mentions which intervention would help prevent preterm delivery, and this would be to suggest that the client avoid smoking. Now moving on to the signs and symptoms. The key signs of preterm labor, which you would want to notify the healthcare provider about, include rupture of the membranes at 20 to 37 weeks. This is basically that water breaking. So you want to report watery discharge from the vagina as mentioned by ATI. Now another NCLEX tip is to report that low back pain. Number 3, contractions every 10 minutes or less, pelvic pressure, and diarrhea. Now HESI mentions signs of preterm labor with a client at 28 weeks gestation, which client statement indicates a need for further teaching. Select all that apply. I expect the discharge from my vagina will change from thick to brown over the next 2 weeks. The baby's movements will decrease and be almost still from here on out. And I should expect low back pain and diarrhea as the baby grows. And moving on to diagnostics. A pelvic exam will show cervical changes that indicate labor, specifically cervical dilation, shortening, softening, and thinning. So a speculum exam can be used to visualize the cervix. This includes effacement, so that thinning of the cervix, dilation, which is the opening of the cervix. And remember, any cervix dilation would show, even 2 centimeters. Fetal membranes, so this would show if they are intact or ruptured, also referred to water breaking. This is that PROM, the premature rupture of membranes. Another important diagnostic test is the fetal fibronectin test, the FFN. This indicates the client is at a high risk for preterm delivery, typically in the next 2 weeks, as fetal fibronectin is like glue that keeps the cervix closed. So if glue is seen, that means it's falling out and the cervix is opening up. Another diagnostic is the transvaginal ultrasound, which is done less than 34 weeks. An ultrasound probe is inserted through the vagina to assess the cervix and uterus. Now remember, a shortened cervix length is a big risk factor for preterm labor. HESI mentions a client is at 26 weeks of gestation, which finding indicates that preterm labor is occurring. And this would be that the cervix is effacing and dilated to 2 centimeters. Now let's talk about preventative measures. Prophylactic cervical cerclage can be done to prevent preterm delivery. A heavy suture is placed transvaginally or abdominally to keep the internal cervical os closed during pregnancy. Placement is common for clients with cervical insufficiency at 12 to 28 weeks gestation. This is where clients experience painless, premature cervical dilation and miscarriage, or present with a short cervix or history of preterm delivery. Now, stitches are removed at 36 to 37 weeks. Now let's talk about interventions. Firstly, we have education after the cerclage, basically after that suture is in place. This includes activity restriction and bed rest for a few days after the procedure. No sexual intercourse as it can cause damage to the sutures. Mild abdominal cramping is to be expected, so make sure you educate your patients about this. And you want to assess fetal movement daily, as mentioned by HESI. Now, some signs of preterm labor to report. Firstly is that rupture of membranes. So you want to report any watery discharge from the vagina, as mentioned by ATI. Low back pain. This is a huge NCLEX tip. You definitely want to report that low back pain as it's a sign of preterm labor. And lastly, contractions and pelvic pressure. This must be reported to the HCP. Early removal is indicated if there is a full rupture of membranes, and this is done to prevent infection or if preterm labor initiates to prevent damage to the cervix as it dilates. Now, continuous fetal monitoring is required for clients in preterm labor. This is done to assess the frequency and duration of contractions. And lastly, amniotomy or AROM is contraindicated. Remember, this procedure is done to manually induce labor by rupturing the amniotic membranes. Now, we do not want to do this in preterm labor. The goal is to prolong pregnancy as long as possible. Now, as a side note, clients who have a history of preterm labor are commonly prescribed progesterone throughout the pregnancy. This will reduce the risk for future preterm labor. Now let's go back to general preterm labor and discuss some pharmacology as it's critical. So be sure to write these 4 NCLEX tips down. Number 1 is antibiotics, and a lot of students get this wrong on Select All That Apply questions. We want to administer penicillin IV through the piggyback route, as this prevents group B strep infections. Number 2 are steroids, like antenatal glucocorticoids. Think steroids act to stimulate surfactant for fetal lung maturity. And the one you want to give is betamethasone. Think of the S's, the steroid zone. Third are tocolytic agents. They are given to relax the uterus in order to prevent labor. And it helps slow down the contractions in order to keep that baby inside the uterus for longer. This allows time for these steroids to have the most therapeutic effect. So write down these drugs. Terbutaline. Think terbutaline calms those turbulent contractions. Other tocolytics include nifedipine and indomethacin, the NSAID, which cannot be used longer than 72 hours or after 32 weeks gestation, as it can prematurely close holes within the baby's heart. Lastly is magnesium sulfate, which is another tocolytic. It's given specifically to preterm babies for neuroprotection. It reduces brain swelling after delivery and helps to relax the CNS during that stressful preterm labor. So write this down. It protects the baby's brain, also called neuroprotection, and it reduces that risk for cerebral palsy. And as always, you want that continuous fetal monitoring because it is required for magnesium sulfate infusions. Since magnesium mellows the body, it helps to mellow the uterus, to stop labor, but toxicity is a major concern. So mag can mellow the body too much and slow the mother's vital signs. So the big toxicity signs here, we want to monitor the mother's respiratory rate, blood pressure, and DTRs, those deep tendon reflexes. Now we want to discontinue magnesium if we find low respiratory rate, a low blood pressure, and depressed DTRs, as these are signs of magnesium toxicity. Now the antidote we want to have on hand is calcium gluconate. Just think gluconate helps to glue down the muscles. Now let's go over some top missed NCLEX questions. First, a pregnant client is admitted for preterm labor at 30 weeks gestation. Which treatment options should the nurse anticipate? Select all that apply. Intramuscular betamethasone, yes, that's for that lung maturity in the fetus. Penicillin via the IV piggyback, that is to fight the infection. IV magnesium sulfate for the neuroprotection. And calcium gluconate. Have that ready just in case there's any signs of magnesium toxicity after the delivery. Moving on to HESI. Magnesium sulfate is used to prevent preterm labor. Which would the nurse assess in the client to determine drug toxicity? This would be respiratory status, level of consciousness or LOC, and the deep tendon reflexes. And Kaplan mentions magnesium sulfate IV. The client's deep tendon reflexes are decreased. Which action does the nurse take first? And this would be to discontinue the IV infusion. Lastly, some ATI questions. 30 weeks of gestation, which medication is used to accelerate fetal lung maturity? And the answer here is betamethasone. And lastly, question 2 goes over terbutaline. Which of the following client statements indicates an understanding of the teaching? The answer here is, this medication is used to stop my contractions.
All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download